Okie dokie. So this is more apropos of that. Before I was so interestingly interrupted. All right. So this is basically we're concluding the red blood cell. I wanted to do the white blood cell one because we do the white blood cell one. I like to try to do a count on that, and it's just a couple of the exercises that we do in that particular lab. So I think I have everything, and we'll go from there. So it's really not enough for too many. Anemia is not enough, and anemia. I mean, you'll hear the term called aplastic anemia. It means anemia means not enough being formed. Aplastic anemia, anemia just means it probably means not enough cells, and typically anemia, unless there's another adjective, it's the implication is red blood cells. Where aplastic anemia means there's something suppressing the bone marrow, and usually the problem with that is because there's so many, just 1/1000th of the number of white cells. That really is impactful vis-a-vis infection. Because people with aplastic anemia, their bone marrow collapses. That was a big complication of certain medications, and other things can cause it that are there. So I mean, I just wanted to clarify that now that I was thinking about it. So, and poly, too many. So anemia, basically can't carry enough oxygen. It's all about the underlying disease. When I had this profound anemia that you couldn't walk with, couldn't do anything with, it was chronic blood loss. Okay. And then we classify it other ways with not enough being produced or too many. But the signs and symptoms. And again, a sign is something that's measurable, like measuring and doing a blood test. Observable or measurable. Pallor would be observable because you could see the color. Dyspnea would be difficulty breathing. You could observe that. Fatigue is something that's not. Yeah. It's just something that the person would describe. If you want to think of it that way. So if it's rapid, then we have to replace the blood. It's about the only reason we utilize whole blood for transfusions. The flip side of that is like what I had, bleeding ulcer. And then it was a question of getting the underlying disease addressed and then appropriately treated, with yet another monster surgery that I had. So a lot of these iron deficiency is fairly common comparatively. And if you wanted to actually, you're almost since you're losing blood when you're hemorrhaging either acutely or chronically, internally or externally, you're not able to retain the iron. So to a certain extent, that's somewhat of an iron deficiency anemia. Okay, so its underlying cause can be hemorrhagic, but the one they're talking about here is iron intake. And it's just some people can't, and what's characterized by, again, since there's not enough iron, there's not enough hemoglobin, and the cells, because they can't form properly, okay, actually are very, very small because they don't have a sufficient amount of hemoglobin and they're pale. So we call it a microcytic for small cells anemia. And then there's additional studies you can do. And since we're going in the lab, I really should try to hook up to show you what the indices are for this. Hopefully I will remember to. If not, I'll make sure I get that in on Wednesday. So they're small and they're pale in color. Okay. For these kinds of things, yes, the treatment is iron supplement. Some people is more difficult. There may be other factors that are part of it. When the cells have not matured, typically it's not folic acid, though it could be. There's enough folic acid around, but B12 is a problem. An autoimmune disease that can lead to that destroys intrinsic factor, which is made by your gut. The reality is that some people, for whatever reason, like with my surgery, probably made less intrinsic factors since they removed half my stomach on 2 occasions. So I did B12 supplements. It was sufficient to do that. And they led to large cells. My cells were large, and they were borderline low in what's called hemoglobin concentration. They're still on the large size. They're still on the low side for concentration. I had enough intrinsic factors so the B12 worked orally. A lot of people have to do it by injection. And if I didn't tell you before, that's the inherent problem, is that most sources for B12 are animal based, so they're not. Vegans have problems. Yes, sir.
Are there certain bacteria?
Really?
Yep.
Interesting. I mean, because we're looking at so many different sources. I mean, I have no. I personally don't have issues with vegan lifestyles at all. I think it's a reasonable alternative. There's become an over reliance on chemically manufactured foods, and now it's hard to be vegan and to avoid GMO. It's just that the two don't play well together. They make stuff that's so convincingly looking and tasting these days that are there. But I'm thinking about doing that for Science Day because what Science Day is the 5th of May, Cinco de Mayo. So I've got a really good recipe for this pork al pastor to make tacos, and I've got to come up with it. I'll make vegan. I'll have tofu tacos. Hey, tofu's good eats. It's a great canvas for big flavors. So we're going to use big flavors. Get in touch with our inner chipotles. So that's any kind of anemia. If your kidneys don't work, you can't make erythropoietin. That's renal anemia. That's why they utilize genetically manufactured EPO. This is the aplastic anemia. Typically, I have seen it with drugs. Notoriously, it was a very famous antibiotic called chloromycetin, known as chloramphenicol, which was taken not off the market, but everybody stopped using it. Okay, but it affects all the lines. But really, the immunity was the part that really was the most immediate problem, even more so than the clotting that was there. And then you have hemolytic anemias, and this is typically an underlying problem. It can be autoimmune in nature. There's a variety of conditions that lead to it, which is sort of beyond what our scope is. The more common things, transfusions, which we're going to talk about today for lab, a little bit when we get ready to do the lab, and the genetic hemoglobin abnormalities. So you have sickle cell is the classic example. Okay, without going crazy about it, because I'm sure you've covered this genetically, you've covered this in other courses. Effectively, what makes cells sickle is lack of available oxygen. It used to be thought to only manifest itself in the disease, which is autosomal recessive in nature. Now we know the trait causes the same degree of, not the same, but can cause similar problems, equally severe, depending on the circumstances. Ryan Clark, Denver, ruptured spleen, out of his gallbladder, nearly died, and he was a trait carrier. So people now know this in sport, particularly, that there's a significant risk associated with it. Thalassemias, the way I learned about them, they were called major and minor thalassemias. There's a lot of variations genetically. It's known as familial Mediterranean anemia. So there were some, and the subtypes are the different thing, from extremely severe, where it might require multiple transfusions, to comparatively minor. And so if you're interested in looking at them, that's something you can research on your own. You can look at it on your own. And here's the sickle cell one. They've been around forever. I've treated all. I learned a lot about people with sickle cell anemia because if they have tremendous pain, because it blocks circulation to organs, hence what caused his spleen to rupture and his gallbladder to basically have to be removed because of damage. We were treating for skin ulcerations, and a clinic that was dedicated to that at the Medical College of Virginia, and one of my mentor there, I spent a couple of months working with. I mean, he's treating these people with giant leg ulcers. I did a lot with wound healing, a lot with how to wrap and dress these things. Very things that were way ahead of their time in wound healing. We're doing there, but I was surprised at how much pain there was associated with it, because it was you effectively clots are forming. So it could be any organ, and the skin is an organ as well. It was really very, and when they went to full blown crisis, that was life threatening. And it would be like all of a sudden, multiple organs would be affected that were there. You probably know that because they don't get malaria, because malaria affects hemoglobin. Okay, individuals with 2 copies of hemoglobin S can develop sickle cell anemia. Individuals with only 1 copy have milder disease and better chance of surviving malaria. So if you have the sickle cell, there's the benefit that's there. And again, because of it's the way it typically presents with folks of African American descent more so than any other group, though not exclusively so. I mean, imagine the amount of malaria is the predominant disease. It's the greatest single killer in equatorial Africa. Nothing else even close. Everybody, well, they have AIDS there and stuff. AIDS is second, measles is third. For all you fans of these recent measles outbreaks, measles is not innocent. And it is for you fans of micro, as far as I know, the most highly contagious infectious disease. This is the old when we were kids before they had the MMR immunizations. 99% of everybody in the world got measles. Everybody. Respiratory. If they could have bioweaponized it, that would have been the doomsday disease. That would have been the Stand. That would have been all that. If you're familiar with that Stephen King thing, they've done a couple of TV series on that. They were actually pretty good. Moving on. So nowadays we have treatments. Years ago we didn't. We didn't know enough about nitric oxide. There are now stem cell transplants. It's one of the areas of gene therapy that's using. You guys familiar with gene therapy? Gene Rayburn, Match Game. That was. I was just. It's right. You're the wrong generation. Gene therapy. We use HIV. You didn't get this in micro. HIV is an RNA retrovirus, right? What does it do? It takes RNA and rewrites it with DNA. We basically use the enzyme, the RNA reverse transcriptase, basically modifying that virus in the laboratory, inserting an RNA sequence to resequence the cells and rewrite their DNA. It's like you're inserting a computer virus. In this case, it's a real virus to overwrite something on the hard drive. Effectively, that's what you're doing. It's in its infancy. So these are all very interesting. So again, something you see the slide all the time. Polycythemia, too many. Who gets it most of the time? Okay, people at elevation and people with respiratory disease. Okay, it's called secondary polycythemia. So you get this. You have to get it if you move up to a place at altitude. If you get a job and end up in Denver, you're going to get this. Okay, but it's normal. Your body will adjust to it. So, and the only time we see it when it's not. That's when you get respiratory illness if you go there rapidly because you basically can't compensate for the lower hemoglobin amount in your body when you talk about mountain sickness or something along those lines, which I happen to get one time. But eventually you'll increase the erythropoietin as long as your kidneys are competent, and you'll be able to, basically deal with the other one that we see around here, respiratory. People, the low oxygen comes from chronic respiratory disease, emphysema, chronic obstructive pulmonary disease, long histories of smoking, environmental factors if they're non-smokers, et cetera, et cetera. And unfortunately, it's really a terrible problem. So when they talk about polycythemia vera, okay, means true polycythemia. Okay, and vera is typically associated with a bone marrow cancer with these ridiculous high levels. And you actually you almost have to take, you could probably have to take off blood, take away the packed cells and put back in the plasma and the other factors if you wanted to do it properly that were there. And then this is the bad part about it: blood doping. Years ago, when they started making Procrit, okay, that was early days. That was what particularly cyclists were always the most notorious about it. Just the whole Lance Armstrong thing. Effectively, they blood doped. We probably talked about that when we did endocrine. Effectively, in his team, in their team medical trailer, they were spinning down their own blood and re-injecting it. They were taking it out periodically. They were holding it. They had it prepped out. They put it back in there. Eventually, they could detect the EPO, but it was harder to detect the blood doping that was there because they didn't necessarily test for that. And so eventually, someone in that camp, it was the U.S. The team was sponsored by the U.S. Postal Service. I mean, you don't win 7 of those in a row. You know, it was unheard of, even though he was a brilliant, brilliant cyclist. Even before, I told you, he survived metastatic cancer. He had testicular cancer, went to his brain, survived it when he was still a world class cyclist. So I mean, I don't even think Barry Bonds, think well, somebody just owned up to another baseball player because they weren't testing today. Mo Vaughn was there with the Red Sox. Yeah, I used HGH. Fine. The blood cells. This is what we're doing. What we're going to try to do is basically do a white count the way we did it in the old days. I'm going to find some peripheral blood smears. Hopefully, I will find them so we can do this. They're the only formed element that's really a cell because it's got a nucleus and organelles. It makes up a relatively small amount, which makes it easier to find, to identify them because you have so many red cells on a peripheral smear. It's easy to find the white cells. Typical numbers, just about right, 4.5 thousand to up to no more than 11,000 per microliter. They are basically the linchpins of your immune system. Down the road, we will look at that. Effectively, what happens, the capillaries have little clefts. When inflammation is triggered, when there's chemical signals that we'll go over in the immune system. Maybe you've done some of this already if you've got Dr. Maurer talking about it. Basically, it will alter those clefts. Proteins will change shape. They'll basically latch on because the white blood cells are slower. The formed elements are more abundant close to the wall rather than the center of the blood vessel. It'll latch on to the white blood cells. Basically, the chemicals will facilitate the diapedesis. Chemicals will allow them, because they can change shape, sort of like slither through. They'll make the cracks bigger so they can slither through the cracks. Okay? Margination. Did you learn about these things? Margination, diapedesis, for those taking immunology? Not there yet? We're going to get there in immune system. You don't have to thank me, it's part of it. And basically, they're attracted by chemicals. To me, it's just like The Price is Right. You get tissue is damaged, it sends out chemicals, it says to the white blood cells, come on down. Price is Right. Come on down. The show drives me crazy. You know why? They have the 4 people. Whoever is batting fourth should win. They get so excited. Who wouldn't? You know, it's like, well, I'll say 875. I'll say 1,000. I'll say, whatever. Somebody else will say, 1,100. If you think they're under, they're over, say $1. If you think it's not enough, 1101. They'll say something like 1099. And I'm like, I want to throw something at the same. You're an idiot. My sons, they went there, a bunch of guys in uniform. They were hoping to get picked. We were stationed out in San Diego years ago. White counts, over 11,000 bad. Normal response to infection. Two categories. Just like the red cell line, this has a dedicated line. They go by 2 names based on granules that stain. all white blood cells have granules. They don't all have visible granules. So we name them granulocytes and agranulocytes. Those are the two cell lines. Visible, and that's the watchword, visible granules. The granules are the chemicals that they utilize in order to do what they have to do, whether it's attacking viruses, parasites, whatever. Granulocytes, okay? Neutrophils, eosinophils, and basophils. We'll see them in a second. Agranulocytes, no visible staining lymphocytes and monocytes. Whatever works, this is the batting order. So basically, in the lab, we're going to create our own. We're going to scan each laboratory table, per se, or group. We'll take a look at, hopefully, and basically mark down. This is the way we used to do it. You'd be in the lab, you'd have a microscope, you'd have a person's peripheral blood smear. You have it like an old way that you used to make change, when we used to use change, and you went to like, oh, you went to like one of those arcades and you wanted to play the games, you need a bunch of quarters, and one of those things, you know what I'm talking about? I think some of you actually know that. And you look down there and you press a different button. Each one you see, you just do a grid search, back and forth, back and forth, back and forth, shift it over. SOP, standard operating procedures. And the mnemonic that works for some, you use your own. This is cruelty to monkeys. Never let monkeys eat bananas. Filet mignon, fine. Okay? The monkeys can have that. Béarnaise sauce, okay. Steak tartare, fine. Oysters Rockefeller are okay but bananas, F you. So here's how it works. Neutrophils, average. Every book, every author differs, but they're all about this, 50 to 70%. They are the most abundant. They're the first on the scene as an infection. They are, when we see those elevated, it points to a bacterial infection. Okay? Next, lymphocytes. They are agranulocytes, as you will see. 25 to 45, good ballpark. Yeah, I've seen 20 to 40. Depends on who you're reading. Effectively, when we see them increased, when the white count is elevated, we look at a viral infection. So if you have a dose of the flu, RSV, whatever, that would go up. If you had a staphylococcal infection, that percentage is called a differential. So, and we gain a lot. It's tremendously important. So after never let monkeys, we have the monkeys, monocytes. Monocytes, which are macrophages when they leave the bloodstream. Neutrophils stay as neutrophils. Lymphocytes, when they leave the bloodstream, basically are lymphocytes. You can't tell them apart. When you see them on peripheral smear, they are probably mostly T cells or something you'll learn about called a natural killer cell. Okay. B cells, they could be B cells morph into something called a plasma cell, which look different. But monocytes, when they're in the tissue, they're macrophages. While they're in the blood, they're monocytes. Typically, monocytes, it's interesting about monocytes, okay, they're probably the easiest ones to detect. And I'm always surprised when people confuse them for lymphocytes. And that's why I'm here to help you look as well. And then you have eosinophils, which are very easy to spot. They have distinctly red staining granules. I'll talk about the neutrophils in a second. And the basophils, which are the hardest to find because they're the least abundant and frankly are rare to find with the slides that we have. They have blue staining granules. When they leave the bloodstream, they become mast cells, and they're the linchpin of allergies. So we will get to all of those. That's so there's immunological function as well. Good illustration. So these are not multiple nuclei, they're multi-lobed nuclei. So you have 3 to 6 typically here, 2 here obscured. The eosinophil, you can see the red granules, nuclei stained blue. Okay, this is a bilobe nuclei here, but the blue granules obscure it. The granules are here, but they don't stain distinctly red or blue. So they call it neutrophil because the stain is neither red, acidic, nor blue, basic. And typically, I've seen what's described as a lilac color or a pale color, whatever. But what makes the nuclei, it's one nucleus, it's just folds, it's twisted. Balloon puppets. Sausage making. Most people have one of those extruders on your KitchenAid big mixer. Make your own sausage. What? I'm crazy. No, just a little less. We have one. We found that at the thrift store, but there wasn't a great market for it. When you find a KitchenAid attachment, they usually go for big bucks. I found a ravioli maker. I underpriced it. My wife is still mad at me. That sold like the next day on eBay because they're hard to find. We're going for 150. I had like I slept in the dog's crate. He slept in bed. You think I'm joking? The dog's as big as I am. What? Yeah, right. Don't believe me. So those are the things. So neutrophils, eosinophils, and basophils, larger, but they don't last as long. The lobe, rather than circular, granules that stain, the stain we use is called right stain. They're all to some extent phagocytic, which is different than macrophages obviously are phagocytic. Lymphocytes are not. And again, that's immunological as well when we start talking about that. So twice the size of a red cell, since it stains acidic and basic. The way they have a lot of things in them, defensins, hydrolytic enzymes, they go by multiple names. We nickname them polys because it's polymorphonuclear leukocyte, many shaped nuclear white blood cells because of the lobes, 3 to 6. If you see 3 lobes, doesn't matter what the color is, it's a neutrophil. Okay, bacteria slayers, it's all those toxic derivatives of oxygen. So basically, they synthesize ones that are in the category like bleach or peroxide, and basically, it shoots out what are called defensins. Okay, they are little tiny proteins that punch holes in the microbe. How's this? How do we kill it? We'll punch holes in its outer boundary and shoot it full of potent oxidizing agents to destroy it. It is not bad from a cell. I mean, to me, the remarkable efficient chemical approach is very interesting. I mean, I'm continually amazed at the magic of the human body. And believe me, bacteria, when you look at their defenses, are equally as interesting. How can a single celled organism with no developed central nervous system, with some of them gram negatives, when you shoot in antibiotics in that periplasm, that area between the outer and inner membrane, they have efflux pumps. They pump it back out. Are you kidding me? They change targets. It's crazy. We really underestimate not just ourselves, but other organisms as well. They're living things. Living thing rule number 1, want to survive. So here's what they look like. Same illustration. You see the EOs. Well, depends on the author. I've seen 1 to 5 is a more common number. 2 lobes, yeah. Red staining granules. Those enzymes, now they play, I've seen them in allergies. I've seen them as well, But when you talk about parasite is a generic term most of the time, something that's invasive, something that occupies you but does you harm, doesn't bring any benefit to you whatsoever. That's a parasite. When they use parasitic infection in a microbiological standpoint, it implies a eukaryotic pathogen. So worms, protozoans, malaria, those where you would see eosinophilia. Okay. My son, who's now 41, was worked up and diagnosed with eosinophilic gastroenteropathy. It was an allergic gastrointestinal problem. It was a year and a half old because he had irritable bowel or variation of that. I mean, and he had a lot of food allergies. Doesn't have now. It's just and because a lot of times they come upon you when you get older, they disappear. He was more of a disappear. So they play a role. Allergies and asthma, immune responses are there, but that's thing. We get rid of the worms, we sort of gobble them up, and then make it it's like into little bite. Imagine your body for macrophages making them out into macrophage bite-sized pieces, so they can gobble them up. Very interesting. And again, that's what they look like. Basophils. If you find one, it's always special. Okay, one or two constrictions, typically bilobed. Very distinct. It's like a shower of those granules. You have to see the granular structure. Students mistake lymphocytes for them. They contain, at the very least, histamine. They become mast cells. They're not just similar to them. Histamine dilates them. They also sometimes have heparin, and they have other chemicals in them. Most of them are pro-inflammatory. Or in the case of heparin, they retard clotting. And again, the agranulocytes, because they're not visible, lymphs and monos, the nucleus is distinctly spherical and involves nearly the whole cell in lymphocytes. That kidney are U-shaped, but what gives a monocyte away is it's big. It's clearly bigger than any other cell. It stands out by, and it has like the nucleus appears to be indented. And it looks like either a letter U, like a fat letter U, or a kidney. So lymphs, very scant amount of cytoplasm. Again, we get into all the different things, but basically you're probably seeing, like I said, T cells and NK cells more than anything else. I mean, just a little bit of cytoplasm, the blue color is there. Monocytes distinctly larger, that distinctive shape. They become macrophages, phagocytic, they sweep up. We all know that they do. There you can see that indentation is there. So that's part of the thing you're going to do, and it's all about really the white blood cells are stimulated mostly by chemical messengers. You start to deal with it in immunology with interleukins and these different colony stimulating factors. Yeah, a little bit. Yeah, I mean, so that's good. I don't understand it enough more than I highlight in my class a few of them. Basically, because of my own, like IL-1, IL-2, IL-17, IL-10, and tumor necrosis factors. Okay. So, but there's so many of these interleukins are this magical way that white blood cells not only communicate with each other, but communicate with different areas of our body to either fight infection or stop fighting infection. So these colony stimulating factors, various types of, some stimulate granulocytes, some don't. They all come from that common origin, and then they change, and you'll see that. We don't have to go into this. When we see something like a band cell, nuclei form a curved arc. It's just like in the blood. When you're fighting an infection, your body is called on to make more white blood cells. How do you know? At first, you're going to have high numbers because that's your body's response. So if we see some immature forms at the start of an infection, we're not surprised because you're pouring out resources. I mean, the way I was explained to me by a pathologist who was lecturing to us, he goes, they're like troops. We have body pools all over with white blood cells. And they just, the minute they an infection, their signal, they pour out stuff like that. If you, down the road, not necessarily initially, But we look at that. If we see immature forms persist over several days, that's bad. Because that means you're losing. And those white blood cells, because they're immature, can't fight very effectively. The other side of that is if we say an abundance of mature, we don't see enough immature forms. We can tell by the nature of these cells, then we're having a very sluggish response that's there. And so it's not pouring them out, it's just not pouring them out very efficiently. So the numbers will either be low or obviously show signs of deterioration already because they don't have a long lifespan. Now you got another problem. That's one of the things that clinicians look for. Why you don't repeat tests every day, but you repeat them at intervals. So we look for a variety of things. 10 times more are stored in bone marrow than in blood, as you can see. Okay, they become segmented before they're released. 3 times more white blood cells are formed than white blood cells because white blood cells have a shorter life. Because that's what they do. Effectively, they die when they're fighting microbes. I mean, and I go into this in immune system. What's pus? Pus is tissue debris, dead, not living bacteria. Why you don't culture pus to solve an infection, and a whole bunch of used up white blood cells. They're there. So I mean, when you're trying to find out, people make this. It's hard. They culture the pus. I mean, all it's going to tell you is a bad story. You got to be an aggressive clinician. Take something, wipe that, even though it hurts the patient, you want to get down to the bare wound and swab the interior and the sides, the base and the sides. That's where the bad guys are. They're not going to love you, but they'll love you more if you get them better. It drives me crazy. I, Particularly when you're dealing with, in critical care situation, you cannot play fast and loose with it. Moving on. So, and these, and the different thing is we'll get to, and you probably have gotten to this in immune for those taking it, is basically this is where the thymus, all white blood cells are born in the bone marrow. What we call T cells, they mature in the thymus. B cells mature in the bone marrow. And there's terminology about maturation and competency and all that, which is very annoying, but it's part of the deal. So these are the committed lines. And so why this is important when we hear about leukemias, basically cancers of the bone marrow that involve the white blood cell line, we hear terms like myelogenous, those are the granulocytes, and lymphocytic, those are the agranulocytes that are there. So we use this to try to stimulate bone marrow. There's so much that's done in an effort to do this. Right? I mean, stem cell transplants are certainly being used, but bone marrow transplants have really, really changed things dramatically. They were very rare to use. We were just hearing about them. When I was learning about this, the way that you diagnose anemia, the way that you diagnose irregularities, if you suspect leukemia or some irregularity in the bone marrow, like multiple myeloma, which is really a failure in and involve another kind of bone marrow cancer. You have to do a bone marrow aspiration. So, and you either take it from sternum or from hip, your iliac crest, because they're close to the surface. And you suck out, you have to bore a little hole, and it's not pleasant. You numb the skin, then you basically poke a hole. You actually use a trephine, a little, like a circular kind of a little, saw is the wrong term, almost like a file like with little teeth on it. Back and forth it, punch a hole, stick a syringe, and suck out the bone marrow. It looks like blood, but there's a thickness to it, and that's how you analyze these things. Then you can see how the forms are developing. So they're really important when you're doing workups like this, and like for the MCAT students, that's the kind of stuff that we do at bedside. Typically, we used to see that, and they probably take them to short stay procedures. Uh, I was seeing, when I was getting transfusions like crazy, I'm seeing liver biopsies, bone marrow aspirations. Not seeing them, they're doing them in that medical unit where they're getting the transfusions and just pulling the curtain. So again, overproduction, leukemias. Mono is an infectious sort of it. It doesn't mean monocytes, it means mononuclear forms. So even though years ago they saw these enormous monocytes and named it, the reality is you see a lot of lymphocytes and monocytes as well. And if it's low, yeah, you start thinking about medication-related things, anti-cancer drugs. Unfortunately, also thinking about HIV/AIDS. So leukemias, cancers that are there, they are one line, the myeloid or myelogenic or the lymphocytic, based on the abundance of cells. When they say acute, it's typically children, it's not good. Chronic, typically older folks, easier to treat. It doesn't preclude chronic in children or acute in older both senior citizens and just older patients that are there. The diagnoses are not great. Neither one. I mean, you wouldn't want that because there's so many attendant problems that are associated with it. And they did that. I told you about that text, Emperor of All Maladies. One of the earliest ones they were talking about were leukemias. So when we started, in the very early chapters, before he got into histories, he was talking about ways that they were identifying and treating leukemias in the 1800s, that type of stuff. So they were aware. They had a microscope. They could see white blood cells and things like that. It's very interesting. So without treatment, they're fatal because the fact that there are more of them doesn't make them better. They're non-functional. There is the problem. Crowding out lines, all the attendant problems. You don't have enough proper development of anything else. Typically, hemorrhage is part of it, or infections. And infections would be first. And again, we have more ways of treating it. Good old Epstein-Barr, herpes virus that are there, also associated with cancers, if you did not know that, but not terribly common. And so the lymphocytes became enlarged. Originally, I thought it was monos, was only, hence it got its name. And it's a great masquerader. That's one of the things. It's like what Hannah was talking about. Lupus is like that too. In other words, you have different signs and symptoms. It can be anemias, it can be tiredness. I mean, a lot of times it's a very interesting differential diagnosis. I mean, one of the is strep throat. I mean, you'll see typical they look like reddish nodules in the throat that would typically be swollen nose with what appears to be pus on them. The reality is sometimes they're mononucleosis. My stepdaughter had when she went to Allegheny, and that was it. And they actually found out she had mono because they had this. I'm seeing pictures of the throat. It's like, oh my goodness, strep throat. No, never tested positive. Not either on the rapid or her actual throat culture. So they ended up treating her for mono way back then. Let's stop it here because that's the clotting cascade. We're going to do that in lecture, and then we'll talk a little bit about transfusions in lab and do our lab at 4:30. Thank you.